Hey now, hello and welcome to episode 114 of Chairside Live. We've got a good episode for you today. We've got part two of my interview with Dr. Gary Radz, and in this part of the interview, Gary is kind enough to share a couple of his clinical cases with us. So he's actually going to walk us through some of his clinical cases, and we'll take a look at what he's doing with a couple different products, including LuxaCore Z, the product that he helped invent for them and still one of my favorite build-up materials. But before we get to the interview, we are going to take a look at our case of the week. And when you grew up, maybe you had an old man next door, an old kind of crotchety, grouchy old man who you knew how to really make him angry, whether it was walking through his flowers to go get your football, or whether it was bouncing the baseball or the tennis ball off the side of his house because you wanted to see Mount Old Man erupt in the front yard. You knew there was always something you could do that would really get him agitated, get him angry, and get the hairs on the back of his neck to stand up. And I have something like that too. And it's a certain type of impression that we get, and we happen to get one today, and it is our case of the week. So before I get too angry and my face turns red and I start spitting all over, let's take a look at the case of the week. If I ever have a greatest hits album, what I'm about to share with you is going to be the last cut on side one. You know, this is the power song that everything revolves around. And when you see me live, this will be the encore that people scream for. It's something that I seem to rant about a lot, and we see it happen again today. One of the technical advisors had a question brought up on my desk. It's the 4-unit bridge in the double arch tray, in the triple tray, and that's really kind of a violation of what these trays were designed for. We've gone over it, a lot of times before. They're great for single crown preps or two single crown preps that are adjacent to each other, but they're really contraindicated for 4-unit bridges, and especially when it contains the most distal tooth in the arch. In fact, some dentists don't even like to use it when you're taking an impression of a crown prep where you're doing the most distal tooth in the arch, because for the potential of overclosure and things like that. And so this kind of violates both of those things. And so you probably won't be surprised when you see the model. But before we get there, if you're really, and look at this as well, if we've got our 4-unit bridge here, from the distal abutment to the mesial abutment, and then one other tooth essentially that we've impressed. Obviously, it's going to be pretty difficult to get a centric stop, let alone any kind of excursions, without having an impression that goes around the rest of the arch. If we just look at the margins here, at least here I can see some material beyond the margin, which is now, my personal kind of signpost for whether or not I've taken a good impression. But then in other areas, like on that distal, the end of the impression is the margin as well. And on the mesial, the same thing. It becomes very difficult to trim those dies if we don't have that material beyond the margin. So as we look around, a lot of what we see here does not have that flash material beyond the margin. Even just a little like this is really helpful on the buccal aspect of that molar for getting something cleaner. So if you really are in fact hell-bent on using a double arch tray like this, even though we don't recommend it, I want to introduce you to a tray you may not have seen before from Premier. This is called Alpha, A-L-F-A, Alpha. And if you say, Mike, how am I going to remember that? I'll say, well, how do you remember how to get to work in the morning? You just memorize it. But Alpha actually stands for alginate, A-L, full arch. I think. I may have told myself that, but that's how I remember it anyway. And this is the small version of it. It actually comes in 3 sizes. There's a small, a medium, and a large. So if this doctor had said, well, I don't like taking 2 separate impressions, you could use an upper and lower. Instead of being just this small little thing like this, if you extended the impression material over to the other side, at least we would have all those other teeth on the other side. And yes, we'd rather use something a little more sturdy than a plastic tray like this for a 4-unit bridge. But if you use a stiff, heavy body material in here on both sides, and you can see these little interlocking T's, how the material is going to get hooked in there as well, we stand a much better chance of making a restoration that's going to fit and function well. Now again, this tray was designed for alginate, and so typically what I use these for, if we're, like we just made a sports guard for my son who plays ice hockey, we fill both sides of this with an alginate replacement material, goes in his mouth, bites together and holds it, and it takes care of 2 impressions at the same time. And unlike in some upper alginates where your mouth is wide open and you're kind of drooling, there's something nice. I think it's easier actually than taking an upper and lower alginate separately to bite into something and have your teeth close inside the impression. It's much more comfortable feeling for a patient than it is being wide open with this upper alginate in. So my son tends to gag a little bit and does better when we do the upper and lower at the same time. So you could use this for occlusal guards, you could use these for snoring devices like the Silent Night, for study models. Anytime you're doing something upper and lower, if I was doing a Silent Night or an occlusal guard, I'm going to use an alginate replacement material in here, because alginate's just not quite accurate enough for me, because we can't get multiple pores. I can go pour it right away here in the laboratory, but dentists will send it from the East Coast wrapped in a wet paper towel. So consider using these alpha trays not only for taking impressions for appliances that are going to cover all the teeth or for study models, but if you really insist on doing a double arch tray for a bridge like this, consider using one of these trays, because when you don't, we end up with a case like this one where we have the patient bite together. And this is why it came to me, was they said, well, look, the prep's hitting the opposing tooth. You know, can that be happening? And I said, well, it can, but let's hold this up to the light and see if we can see through at the cuspid. And when we hold it up to the light, we can't see any light through there. So obviously the dentist prepared enough where the cuspid was in fact not touching the opposing tooth, or being very close to touching it as it is here. And for that matter, it's not possible for us to be able to mount this accurately from the bite registration that is contained in this, because it's just this one anterior tooth. You know, if there was one more molar back here, we'd have a 50% chance of getting it correct. But all the posterior teeth have been prepped, and the only thing that's unprepped here is this lateral incisor, and there's just no way we're going to be able to get that right. This is for a PFM bridge, so you can see, whereas now, you know, we've talked about how we design most of our restorations 100 microns out of occlusion to make up for errors in the temporary and to keep you from having to do excessive occlusal adjustment. This is the old style way of doing this on a PFM case like this, where we have this foil that's actually 100 microns thick, and we can put this over the opposing and create the space that way. Now we do it virtually on any of our CAD/CAM restorations, but this was in fact for a PFM bridge. And so, you know, unfortunately at this point, this is going to have to go back to the doctor. Doctor's going to have the patient back in again, and we're going to have to get a new impression, a full arch impression, and you feel bad for the patient having to go through this a second time, but there's no way for us to get this correct. You know, we can trim the dies and make the bridge fit, and I suppose we could send you know, a metal framework to the doctor and have him do the bite that way, but we want a tripod. We want to be able to have the bite registration here. Ideally, what we would have is a full upper impression, full lower impression, and a bite registration, you know, squirted here and here, and against just on the literally occlusal third of these preparations, and then on the occlusal third of the teeth across from it. Of course, we don't have a tooth across from this one, so we could send this and use that as part of the bite registration. They actually printed up on our 3D printer a full contour bridge as well, just to be able to check and see how thin that was going to be. And of course, this is just an incorrect bite. He did in fact reduce enough. And so this is a poor patient is going to have to come back and have this all done again. If we take a little closer look and zoom in a bit here, this is the solid model from that port. And you can see on the buccal, I mentioned the areas where there was a little bit of flash beyond the impression. And you can see when the technician goes to trim it, there's a clear demarcation between where the gingiva is and where the tooth is. And that makes it very easy to trim. We come over on the lingual, and it gets a little bit tougher because there's no space. You can say to yourself, well, I can see where it is. Well, I know, but when you go to trim it, it falls apart as it comes to that area, versus actually having a space like we do on the buccal. Well, not the entire, well, pretty much the entire buccal, from the mesial buccal line angle to the distal buccal. Then on the bicuspid, just the tiniest of spaces right there, just a little bit on the lingual, and then you can see it just kind of blends in. And so our technicians end up doing a lot of guessing when they go to trim this, and you know, they have to do that day in and day out, and we'll do it. But with a little more attention paid to retraction, we can end up with an impression that has a lot more material beyond the margin. And we don't need a lot more. We just need the same amount that we have here all around those teeth. And that's going to allow them to trim some dies that are going to be hopefully highly accurate, but there just wasn't a ton of retraction that was done in this case. So again, the best way to do this is going to be with a metal tray, full upper, full lower, and a bite registration on these 2 teeth, even though there's not an opposing one here, but just with the bite registration on the anterior prep and the tooth across from that, we're going to be able to work with that, considering that we have all these other natural teeth on the other side that are going to be in occlusion as well. And so that's the right way to do this. Again, if you want to really take a shortcut and do a double arch impression technique, consider using the alpha tray, even though it was designed for alginates and alginate replacements. If you really want to use that technique here, you can get polyvinyl in both sides of this. And with that full arch impression, like I said, at least we're going to have a much better chance of making a bridge that fits and functions well in protrusive and lateral excursions.
Let me pull up, I know you sent me a couple cases. Okay, there we go. That looks like the 2 forms of LuxaCore Z. The Z stands for zirconia, I'm guessing.
Yeah, we've gone through, this is our 3rd generation of LuxaCore. The first one was self-care, the second one was dual care. And then probably about the same time you were working on Bruxer and zirconium was becoming our buzzword, we were trying to figure out how can we make this even better, because LuxaCore was working, but now we had a lot of copycats out. So trying to stay ahead of the curve and making our product even better. I went to the Germans about 5 or 6 years ago and said, let's make this stronger, because the only thing that's really important about a core material is that it's strong.
Yep.
So we added zirconium about 4 years ago.
There's the LuxaCore. So walk me through this case, Gary. This looks like, oh, hey, you got somebody to say yes to a cast gold crown. You must be more persuasive than I am.
It's probably one of my parents.
Yeah, they couldn't say no. So are you going to be prepping both these teeth in front of it?
Yeah. The first molar is going to be a crown, and the premolar was going to be prepped for an inlay.
And there you go. You've prepped both of those and clean them out. And you're looking at this now, and you're probably thinking that you might want to build that up. I'm guessing if you look at that first molar, what it looks like now, by the time you're done prepping that, what would you have left if you didn't build it up?
Right. There's not, your retention resistance form is going to be really poor, and your contours are going to be not good. So if you're trying to scan it, it's going to be tough to scan and scan well.
And even the walls are going to, the buccal and lingual walls are going to be very thin. I'd be worried about that as well. And this was just kind of, if we go back to that first slide, this was an MOD amalgam. This wasn't any kind of huge bombed out restoration, but by the time you take that out and clean out any recurrent decay, you end up with this. And in my book, when you're looking at a first molar that looks like this one, it's cleaned out, that's going to need to be built. You're going to build that up almost 100% of the time, Gary, aren't you?
Yep, every single time.
So here you put, tell us what you've done here.
Okay, so we mentioned time, Mike, and one of the things I would share, since we've got the clinical case up here, it's very possible to do these in a short period of time. When I'm out teaching, I always try, this is one of the cases, it's old, and but I still show it all the time, is you can do this so quickly. One of the keys here, the matrix that's on there, it's an Omni matrix that you get from Ultranet. And the nice thing about the Omni matrix is that no matter which way you put it, because it's on a swivel, you never put it on backwards.
Right.
You know how when you and I put the matrix on, we always put it on backwards and then have to back up and redo it. So this one always goes on the right way every time. So I've got the matrix on quickly. My isolation, you can get good cotton wool isolation, use an isolate, whatever. You don't have to put a rubber dam on. So we get the matrix in place. Now, etch, prime, and bond, 60 seconds.
And so we've got that in place, and there's the etch, yes?
Uh-huh. And we'll skip the priming and bonding step. And then, the beauty of LuxaCore is like the idea of LuxTemp, I wanted something injectable to be fast to use. So it's in a gun like your light body impression material is. It's in that type of a gun. And you just squeeze it out, and the shrinkage, the other important physical property in this is the shrinkage is less than 2%, so we don't have to worry about polymerization shrinkage instead of steady associated with it. So you just loaded it in bulk. I mean, this is probably the first bulk fill composite that was on the market 15 years ago. We just never thought about it that way. You put it in bulk and light cure it for 30 seconds, and now you're ready to cut.
Nice looking prep, Gary.
But now you got something you can scan. You're going to get a great scan out for that. I mean, again, that's old. It was before I was ever scanning anything. But
so let's look at the second case here. Oh, I love these. Did this come back from the endodontist like that?
Oh, that patient just showed up. That's not my root canal fill.
Well, a lot of times, I shouldn't say endodontist, but a lot of times you see temporary fills like this, where instead of placing a matrix band, the dentist just crammed it in and decided to engage the undercut on the second bicuspid, which works really well, but then when you take it out, the gingiva looks awful. I mean, it's just been irritated by this temp. And as we look at this next picture, it looks like you had to go in there with your diode laser.
Exactly. Yeah, that tissue is hamburger, so use the diode in there to clean it out so I could see, find a margin.
And again, this is one I'd like to think that every dentist in America would build this up, right?
If you don't, there's nothing left. Once you
I know you really can't prep it at this point. You either build it up with something like LuxaCore or build it up with an implant by taking it out and putting in the implant. But that's a good look at what you can do in terms of hemostasis and removing super irritated tissue with the diode laser, because that's pretty clean, and you've still been able to expose that margin on the distal, yes?
Yeah. The diode is invaluable, and they're so inexpensive anymore.
They're so inexpensive, and if you're going to ever find yourself working around implant abutments or screws, I mean, you can't use an electrosurge, so they're a little slower than an electrosurge, but by the same token, they can be used everywhere, and they have a better hemostatic effect. I love how that matrix fits, Gary. You've got that just perfect around the entire margin of that.
Yeah, and a little trick. I mean, sometimes, don't put it to the buccal, put it to the lingual, because I had a lingual cusp to work with. I didn't have a buccal cusp.
Yeah, that's a good point. So had you flipped it the other way when you tightened it, it would have kind of collapsed into that space where the buccal cusp used to be.
Yeah.
And what are you going to drop a couple titanium or metal posts in here at this point?
These are going to be resin reinforced. The black dots on top, it looks like they're metal, Mike, because those are black dots on.
I was joking, Gary. I knew you would never put a metal post in the gym. There would have to be a gun to your head, or somebody at your house with a gun to your family's head saying, "Put this metal post in."
I was trying to be polite.
I know, thank you. But whose post system is that?
I believe that is probably DMG's, because I think I photographed this for an educational series for them. But what I'm using here, Mike, the cool thing about this is, and you'll see this, I'm sure, in the lab too, a lot of dentists aren't putting posts in. Well, you guys may or may not know because you don't see the x-rays. But dentists don't put the posts in. Again, same reason they don't do the build-ups. They think it's going to take more time. With the LuxaCore, I use that for my cement because it's a dual cure product. And the film thickness is 30 microns, so it's well below the tolerance we need for film thickness. So what I did here is I injected the two post holes just until I could see the LuxaCore just coming out of where the post hole was.
Right.
Put the post in, hold it with my finger, and then come in and light cure it so that the post can't get pushed out by hydrostatic pressure. So I light cure that for 5 seconds is all it needs, and then I fill the rest of it up.
Right, and so you're using, again, just to make that point, you're using the build-up material as the cement material, as opposed to using like a separate self-adhesive resin cement to put the post in and then using a composite build-up on top of that.
The bond strengths are probably better because I'm etch priming and bonding down that post space, so I've probably got better bond strength.
And if you do it quick enough, you can probably squirt the material into into the post holes, put the posts in, cure it for 5 seconds, and then still be able to use that same syringe without having to put a new mixing tip on.
Yeah, it's not going to sit in the tip for about 2 to 3 minutes. So.
Right, and that's what you're doing there. You're doing your bulk fill, your the rest of your soft serve ice cream, as we call it. As you kind of go around and put it around those posts. The post placement. I don't know how many times years ago I had to experiment with that and pull a temporary off and have the buildup inside the temporary to say, you know what, I'm never not using a post again, or 2 posts, in this case. And it's even better if the angulation happens to be they kind of cross over like an X at the top and get a little more mechanical retention there.
Yeah.
But that wasn't a difficult buildup for you to do. I could tell that it took just mere minutes to go through and do that.
5-6 minutes, and that's done, ready. And again, Mike, back to the financial end, how much do we get paid for a post?
Right.
$300. Why leave it on the table? And that teeth, without a post in it, that's never going to last.
Never going to last.
I know this has gone 8 years.
Yeah, this tooth is still compromised despite you doing your best to reinforce it as much as possible, but certainly compared to a virgin tooth or just a regular tooth with a crown on it, we need all the help we can get here. So you've got the matrix band off here, and of course that distal open contact actually helps us. We're going to be breaking this contact anyway in just a minute, and there we go. We've got that again. Another gorgeous prep from you. I can't tell if you, I don't know. Did you use the diode laser on the mesial, or did you go in there and scrub it with something like Viscostat?
Actually, I think I put cord around that. I might have had the diode and then gone back with the cord just to expose that margin for the final impression even better.
Right, but again, now when we get this, either as a digital scan from the dentist or a polyvinyl impression that we pour up and then scan it, that to us, we have no idea whether or not that's a virgin tooth, or we don't know that that's built up, we don't know that it has a post in it, so we're able to treat it the best way that we can, and you got a really nice result with whatever that crown is. Do you remember if that's Emax, or do you remember what that is?
I think that's probably one of the first Emax I did.
But I'm guessing you probably haven't placed a single unit PFM in a while either?
PFMs are very rare. I'll tell you where I do them. You get a patient where I can't get an ideal margin. The amalgam went way down.
Right.
I'm not going to do the crown length that I need them to do. I take that diode, I expose it, but the best I can do is get a slice margin in there. That's the rare time I'll go to a PFM, because I need that metal down there acting like a gold crown would for the soft tissue and the fit. That's the only rare occasion. So maybe once every other month I'll have to do a PFM. But it's virtually disappeared from what I do.
It's now literally 9% of the crowns that we do here in the lab. 9% of the posterior crowns, 9% of the anterior crowns. The anterior crowns we do here, 44% are Emax, which is not surprising at all. The surprising number is that 31% are Bruxer. And so I've been shocked that our dentists have been so willing to take this material, which aesthetically is not there with Emax yet, but they've really kind of fallen in love with the strength of it, so they're putting it there. And I'm almost equally as surprised by the 14% of our dentists who are putting Emax on posterior teeth. Emax works great on posterior teeth if you reduce enough, which some of our dentists struggle with, and you're going to be better off bonding it into place there instead of cementing it. So in my mind, I'm like, guys, just use zirconia back there. It only needs to be 0.6 of a millimeter thick. You'll be fine with that. So I'm surprised at both those numbers, but the zirconia in the anterior is interesting. We really underestimated how much dentists care about strength.
Well, I think the other thing that points out, though, Mike, is the aesthetics of zirconia has improved dramatically in the last few years. Compared to what we were doing in 07, 08, 09, aesthetically, instead of just that toilet bowl white that we had back then, the technicians have really gotten much better, and the material, so that we can make it, that you can put it in the front and not be embarrassed by what you put in there. But, I agree with you. I put an Emax on a front tooth every time. But you got a 6-unit bridge with 4 Ponics going from 6 to 11. What's your choice?
Right. And really the biggest thing about those two materials, to me, the Emax and the Bruxer, is, yes, they're strong materials, but it's the story of the monolithic nature of them, that there's nothing fused to the outside of it that can break or chip off later. And it's not a new story. Cast gold was the original, monolithic crown. And I really think that's a big part of why these two materials have been successful, because if you put ceramic on the zirconia, it's going to come off. We've had issues with those restorations. And if you put it on the lithium disilicate, Ivoclar tried that a couple times before they had the stroke of genius to leave the porcelain off and make the whole crown out of lithium disilicate. And that was a stroke of genius. That was amazing and part of the inspiration for full contour zirconia. Interestingly, we're starting to play now with the zirconia that's about half as strong as the current one that we make, but it's still 50% stronger than Emax. And the aesthetics on this are pretty darn nice. And so we haven't put it into production yet, but it could present some sort of a challenge in the anterior as well. But the thing I've enjoyed about Emax is I haven't placed a single Emax veneer that is chipped or broken. And I know had I done all those cases in Empress, I would have had some. Has that been your experience too when it comes to veneers?
No, now you're saying, I was trying to think back. I can't think of an Emax veneer I've had breakage issues with. I can't think of one.
Can you remember Empress ones? That was a test and you passed. I just wanted to see if you were willing to be honest. And it's 3 times as strong. And kudos to Ivoclar. It looks as good. If you had a single central incisor you had to restore, let's say tooth number 8, and you're going to do a veneer on that next to a natural tooth number 9, which hasn't had endo. Neither tooth has had endo. For that single unit veneer next to a natural tooth, are you going to do Empress or Emax today?
I would be comfortable with both. If we don't have occlusion-related issues, I have one technician that actually does a great job with single units. I'd let him do Empress. Otherwise, if it was somebody else, I'd probably do the Emax. I'm so comfortable with it now.
I agree. And to your point, I had a patient the other day who said, I think I chipped one of my veneers. It was actually the owner of this company, Jim Glidewell. And he said, I think I chipped an Emax veneer. And he took something out of his pocket to hand to me. And I was like, no, what am I supposed to do with that? We're not going to run forensic. We're not going to go CSI on this little piece. Let's just put you in the chair and look. And so we looked at the Emax veneers, and I couldn't see anything that chipped. And then I looked down at his lower incisors, and I saw where it had broken off from. And I said, boy, I said, kudos to you, Emax. And I told Jim, this is my kind of material. I said, I left the bite a little off in your protrusive slide, but instead of the material breaking like used to happen with veneers, now with Emax it breaks the opposing tooth, and that's what I need, because I'm not that good at adjusting, protrusive and lateral and things like that. That's how strong it is. We'll actually go to bat for you and remove natural tooth that's opposing it.
Oh, that's good.
One last question before I let you go, Gary. Thank you for being so generous with your time. Have you gotten involved with Chairside CAD/CAM at all? And if not, why? And I think I know, if not, what your answer might be. But I'm just wondering if you got involved at all. Yeah,
I have an iTero scanner, which we use frequently, not 100% of the time. But we're not milling in the office. And I would tell you the reason for that, I've watched the CEREC and E4D and now the CareStream product that's out. The crowns that are coming out are very nice. My problem is it doesn't fit my financial model and my practice. They still can't do veneers the way I need to have them done. And I certainly can't imagine ever being good enough to create 8 of those in a day and be able to give them back to a patient. So when you have a cosmetic-based practice and you're doing 6, 8, 10 unit cases, it doesn't work there. And I'm just me in my office. So my production level of single or 2 unit crowns, I don't feel is big enough to support having that in my office. If I had 3 doctors and one of those machines and an assistant that I could dedicate to it, I could absolutely see bringing one into the office. But with my practice model being the only person here and the type of practice I have, it just doesn't make sense. So it's not like 10 years ago when I looked at that and said, well, these are the ugliest crowns I've ever seen. I don't want to put those in my patients. That's not the case anymore. I mean, they're turning out some really good stuff. But financially, it just doesn't fit my model. It's not going to work. And, again, when you're doing multiple anterior units, not at the level of aesthetics my patients are going to.
Well, that's why I feel so lucky, and I think why I like it so much is because I can prep the tooth or teeth, do the digital scan, and then my favorite technician here at the lab, Cindy, runs upstairs and puts a thumb drive in the back and takes it down to her, takes it down one floor, designs it, mills it, stains and glazes it, and 2 hours later I have a same-day crown where I had to do zero work, and neither did my staff, but it's a trained CDT with 20 years of experience. So the combination of same-day dentistry and the skills of a CDT, I think, could be the future of dentistry. So if you had, let's say you had a dental lab next door to you, and there was a technician where you could send it over and they could do all the work and bring it back to you, that's a different story, right?
Yep, absolutely. Absolutely. Wouldn't hesitate. Not anymore. No. Unfortunately.
Who knows? Maybe
not
somebody's
all of us live in paradise like you did, but.
Yeah, that's true. Yeah, it is. Paradise is the Rocky Mountains, and paradise is living a mile high. And I actually took a friend of mine to the AFC Championship game last year. He's a huge Broncos fan, been a fan all his life. So we came up and watched them crush the Patriots.
Yes.
And that turned out to be his Super Bowl, because the actual Super Bowl started with a bad first snap and only got worse.
Thank you for reminding me of that.
For bringing that back up again. You hadn't thought about that for a few months. I thought I'd bring that back up. But I love Denver. I love fly fishing. I love everything about it. You're lucky to live in such a great area. And I just want to thank you on behalf of myself and all the other dentists for LuxaCore Z. Love that product. And if anybody hasn't had the chance to try it and you're not doing buildups, you're not entirely happy with how soft your buildup material is or how slow it is to cure, definitely give LuxaCore Z a try, because it's a fantastic buildup material. And thank you for all the articles you publish and the things you do and the cases you show like these to help those of us out learn something new. I've never put the matrix band on the lingual before. That's what I learned today. I learned that sometimes when you have that blown out buccal wall, I used to have that ugly, the way the buildup material would go into the matrix band, and it never occurred to me to flip it to the palatal, and I learned that from you. So again, thanks for being so generous with your time today, Gary, and all our viewers appreciate it. Have a great weekend.
All right. Thank you, Mike. It's good talking to you.
Bye-bye.
Well, that about wraps it up for this edition of Chairside Live. My thanks again to Dr. Gary Radz for being so generous with his time and sharing those cases with us. And on behalf of everybody here at the lab, the CSL crew, I want to thank you for your time and your continued commitment to quality dentistry.
He took something out of his pocket to hand to me, and I was like, no, what am I supposed to do with that? We're not going to run forensic. We're not going to go CSI on this little piece.